Hi everyone, and thank you to another episode in the Nico the Vet series, where I'm trying to just explain some of the fundamental concepts in the veterinary arena, relating particularly to the common problems that we see, just so that everyone can have an improved understanding of what's going on with the particular condition that affects their pet. So I thought today what we might tackle is cruciate ligament injuries. Most people have heard about cruciate ligament injuries because they're pretty much one of the most common evils that can befall your knee, whether you're a human, a cat, or a dog. All of us have very much the same knee anatomy, and that's why we're pretty much predisposed to damaging the knee. Because I think of all the joints in the body, the knee, for me, is the most ill-conceived one. Now, I don't for a moment know how to redo the knee design or fix the knee design, but what I do know is of all the joints in the body, it's the one that's just the most ill-fitting and the most likely to fail. Think, for example, of the hip joint. It's a nice sort of tight ball and socket joint, so the ball fits in the socket, and mechanically, it's a nice sort of sound thing that moves around like that. And the hip, the elbow's got three bones coming together, and they fit together quite snugly, and the ulnar, so this bone just over here, has a big sort of a curvy bit that curves around the top of the humerus, which is the upper arm bone. So you've got this sort of nice tight fitting thing that curves around itself. All of that makes sense from a mechanical point of view, whereas the knee joint is pretty much, imagine you've got like a thigh bone coming down and you've got a shin bone at the bottom, and these two are expected to make a hinge. So as you walk, it does that. Now they're very ill-fitting, so there's nothing fitting around anything. They're just two bits of bone that come to a relatively flat surface and then are expected to function like a hinge. So what the body has done to try and stabilize the joint is you have collateral ligaments on either side. So imagine there's a ligament there and there's a ligament there, and that holds the two bones together, and seen from the front, it stops this bone moving this way and this way. In much the same way, if you looked at my finger, I can't bend it that way because there's a collateral ligament there and a collateral ligament there. So it keeps my finger straight, even though it's got a little bit of bend in it. So those two ligaments front and, on the sides, they stop the bones going that way, seen front to back. Then again, seen from the side, imagine you've got the big thigh muscle, the big quadriceps coming down here. The kneecap, it floats just above the bottom of the thigh bone there, and it attaches with the tendon to the shin bone. That's the tendon the doctor taps when they're checking your reflex with a hammer. So that gives you some stability over the whole top of the knee joint, which helps to reduce the two bones moving this way. Because remember, the collaterals have taken care of movement that way, but now we have to stop movement that way. So the quad muscle helps, definitely it does, but it's not enough. So inside of the knee joint, so if we take the thigh bone away for a moment and then turn this and look inside of the top of the shin bone, you've got two ligaments in there called the cruciate ligaments. Cruciate is just the Latin word for a cross, and they're so named because if you look down into the top of the shin bone, having taken the thigh bone away, you'll see the two ligaments cross over each other like that. Now we have one that's slightly more to the front and one is slightly more to the back. So the front one is called the cranial cruciate ligament, and the back one is called the caudal cruciate ligament. In the veterinary world, cranial just means towards the head or the cranium, and caudal means towards the tail or the cauda. In human beings, we talk about anterior and posterior, but it's the same thing. There's a front one and a back one. And the one that tends to fail is the anterior cruciate ligament, the front cruciate ligament. So again, if we imagine the thigh bone up here, the shin bone down the bottom there, it's got all the ligaments we spoke about. And then internally, if you imagine the cruciate sort of runs, it's not showing very well. The cruciate runs sort of like there, and that's the idea behind that is to stop the shin bone sliding forwards. It's not a very good example, but you can see that my little finger there will demonstrate the cruciate. And if I try and move my shin bone forwards, that ligament will catch it. But if I snap that ligament, so boing, now there's nothing holding there. So now this will freely slide backwards and forwards. That's the job of the front cruciate, is to stop the shin bone sliding forwards. The caudal or back cruciate, its job is to stop the shin bone sliding backwards. It's much less important. You can snap, certainly in dogs and cats, you can snap the caudal cruciate ligament, the back one, and not need surgery. You're fine, you can get on with it. It has a much less critical function. But in dogs and in people, once you snap the cranial cruciate ligament, you lose that stability in a forward direction. Also, going back to it being not a great design joint, because there's nothing that really sort of locks into anything else. Inside of the joint, again, if you look at the top of the shin bone, you've got two sort of a crescent moon shaped cartilages sitting, one sort of there and one there. Think of them as basically two little bean bags, because you've got two bones which don't fit together very well. If you put a big squishy bean bag there and another big squishy bean bag there, and then you squish the two joints together, or think of it as maybe two lumps of clay, a lump there and a lump there, and you squash the two bones together, that clay or the beanbag inside will sort of spread out and mold itself a little bit to curve around the surfaces of both bones, and that gives you a little bit of a better fit. So those are called the menisci. Meniscus is one, menisci is two, and you have one on the inside, that's called the medial one, and one on the outside, well, one on the inner aspect of the knee and one on the outer aspect of the knee. So one there, medial and lateral menisci. So yes, they help to sort of improve the congruity of the bones, and I suppose to a minor extent they have a little bit of sort of shock absorbing effect. So why do you snap the cruciate? How do you snap the cruciate? Well, in human beings, it's usually a misadventure injury, and it comes from hyperextending the knee or internally rotating the knee. And what I mean by that is, again, thigh bone, shin bone. As you hyperextend, so how do you hyperextend your leg? If you stepped into a hole, for example, and your knee, because remember your knee's just a hinge doing this. If the knee, this is the shin bone with my foot where my elbow is being, what will happen is as you overstep, the knee goes back. And you can get that effect of your knee going back if you just even step off the pavement onto the road, that little step down, and as you take your weight, your knee goes backwards. Equally, if you were running and you stepped in a hole, as you stepped in the hole, your knee goes back. And that effect of it going back like that sort of bang snaps your cruciate ligament. Also, twisting internally, so just rotating your weight inside. Again, there's a huge element of misadventure. I've seen athletes in prime physical condition tear their cruciates just through this misadventure injury. Dogs, on the other hand, if they tear their cruciates, it can be a misadventure, just bad luck. You stepped awkwardly, but far more likely is they tore their cruciate ligaments because they've got a fundamental problem with the design of their knee. And this is something that for years we didn't appreciate, and we used to, in terms of repair, we used to copy the human repair techniques, and then in our dogs we used to be, more often than not, certainly I was, disappointed by the results we get in terms of healing, meaning people have their cruciate surgery done, whatever form that surgery takes. There are many types, so we'll come to that in a minute, but most people, the prediction and the expectation is, you've had your surgery, you should do very well. In dogs, like I say, we mimic that surgery, we copy that surgery, we do exactly the same, and disappointment. And for years and years and years, we couldn't figure out why. And eventually, we figured out why. A chap with a wonderful name of Dr. Barclay Slocum. You couldn't make that up. It's just marvelous name. Very clever chap. He figured out why it is that dogs rupture their cruciate ligament in the first instance, and that then explains why the human repair techniques are not applicable to the dogs who tore their cruciates. Cats I'll get onto at the end, but the main focus is dogs because they're the main guys who suffer with these problems. So what Dr. Barclay Slocum figured out was shin bone again, thigh bone again. So as the shin bone sits on the thigh bone, the top of the thigh bone, let me get it straight, as it is there, should be parallel to the ground. So basically, as the shin bone sits on top of it, it's in a neutral position. It's not trying to slide forwards, it's not trying to slide backwards, it's not trying to slide left or right. This is perfectly flat. So it just rests on there, and then although you've torn your cruciate, you've still got this tendon, the big glute over the top hold, and obviously the joint capsule holding you together. So the reason dogs don't do well is, if you imagine that's the top of the shin bone, this one here again, that's the top of the shin bone. When they grow, this starts to tilt backwards like that. So now this surface is no longer, that's level to the ground, now it's tilting back. So what happens is, as soon as you take your weight on it, this is your thigh bone, it starts to slide off the back. And because this is so tilted, I'll exaggerate it now, so it's like that. And as it wants to slide off the back, it effectively pushes the shin bone forwards. In the same way, if you try and grab like a slippery marble on a table, for example, as you try and grab it, it sort of pops away from you, that sort of effect. So so because of the tilt in the shin bone, the thigh bone's trying to slide off, and really the only thing that's catching the thigh bone and stopping it sliding off is the cruciate ligament. If I sort of try and represent it like that, it's the cruciate ligament, and as this tries to slide off, this keeps catching it, and effectively that's going on your whole life. So you're tugging at it, and you're doing sort of this to it. Your whole life, you just sort of bang, 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 pulling and stretching it, and that just weakens it over the course of your entire life. The closest you and I will have experienced to that is walking down a very steep hill. And this is why runners will tell you they much prefer running uphill to downhill, because although running uphill takes more effort, there's less pain on them. And that's because as they run downhill, because as human beings, we've got this flat tibial plateau, but as you run downhill, you lean back like this because you're running down the steep hill. So as you lean back, your whole body is turning back like that. And now you're recreating that situation that a dog has, where the thigh bone is not on a level shin bone anymore, and it's trying to slide off. And the runners will tell you that hurts their knees. So the closest we'll experience to what the dogs experience is running down a steep hill. So effectively, the dog, though, doesn't know this, because the dog's had this knee design from the day he was born, and he thinks everybody feels like that, and that's how the knee feels. So you spend years and years and years and years tugging and tugging and tugging away at that ligament as it sort of catches the sliding movement. And of course, you do that to anything long enough, it's going to snap. So for example, take a piece of wire and sit and just bend it and bend and bend it. And you do that long enough, it's going to ultimately snap. So usually the dog will be doing something fairly innocuous when the cruciate snaps. So they don't have to be doing something acrobatic or athletic. I've seen a dog just going out on a toilet walk. She just had surgery for something else. She was very sedentary, very relaxed. In fact, I took her out for the toilet walk, and she was walking beside me on the lawn, having a wee and just having a sort of sniff around, and I heard it go. I thought at first she might have stepped on a branch or something, but I heard the sort of sound, and that was it. She was lame and the cruciate was gone. So that's not because I made her do any sort of spectacular stuff. It was gonna go. And that's important, because people sometimes blame themselves, or they blame, how much exercise, excuse me, the dog did as a puppy, or because they've got stairs at home or something. It's got nothing to do with us as the owner and companion of the dog. It's just a bad design, which was always gonna go. And this explains why, when we apply human repair techniques to the torn cruciate, they just don't work well. And that's because the human repair techniques are based on the model that the top of the shin bone is level. So with us, you can use a graft from the front of your thigh, the muscle there. When you have a roast silver side, for example, that silver lining you see on the outside of the meat, we can take a strip of that and use that to push through the joint and make a new false ligament. On that subject, in people, when they tear the cruciate ligament, we're just very much bigger than dogs. And because ours is a misadventure injury, sometimes they can do a primary repair, which is to say, if that's the tendon and it's the ligament, I beg your pardon, if that snaps, they can then stitch it back together again, and we may do okay. In dogs, when the cruciate ligament snaps, you go in and have a look. It's like a mop head. You've just got all these loose, scraggly pieces. There's not much substance to them left. It's worn out over years. So with us, just primary repair is not an option. So if you try and apply the human model again, so you've got this flat shin bone, you do repair techniques. The reason they fail is because the shin bone is still tilted back. So whatever repair you do, the thigh bone, this one here, is still trying to slide off the back. So whatever repair you do, whether you use some of your own tissue to make a graft in there, or for years we used like a nylon band on the outside of the knee, or even a wire band on the outside of the knee to try to stop the two bones moving relative to each other. Well, again, you take anything and you bend it long enough, it's going to go. So that technique was called the DeAngelis suture, and you use modifications of the DeAngelis, and even in the modern days you get like a tightrope system. All of those are designed on putting something, a wire, a nylon band, a braided thing, whatever you like, on the outside of the knee to try to stop that movement, but the same forces are going to snap it again. So it was this clever chap, Barclay Slocum, he's the guy who figured out that you must correct that tilt in the shin bone. If you do not correct that tilt backwards, you're going to just keep sliding off the back. So how do you correct the tilt? Various ways. The way he came up with was, because remember this is important now, you've got the kneecap sitting on the front of it all here with the tendon coming down the bottom. And he came up with an idea of making a circular cut, so like a watch face, a circular cut just like that, and you free up what's called the tibial plateau. That's the bit of tibia you walk on. You figured out, make a circular cut like that, and you can take it like a watch face then and turn it level. I've got a little model here, and I don't know how successful this is going to be, but that is intended to show here's the thigh bone there's the kneecap on the top, and this here is the shin bone that you see here. And what Barclay Slocum said was, this is the top that you want to walk on, and if it's tilted back, fundamentally what you do is he made a circular cut, which you can see there, and he slides it back. So you can see what that does is that has the effect of sliding all the way back, and that levels the top of the tibial plateau. So that's the surgery. It's just a very, very carefully placed, very, very precisely placed circular cut, and then tilt that to straighten up the top of that so it's parallel to the ground. So he came up with this technique. It does involve, yes, it didn't basically you're breaking your leg, you're cutting your leg, rotate that to the top of the tibial plateau is level, and now the shin bone, the thigh bone is resting on the level top of the shin bone. You have to put a big bone plate in to hold it back together again. Healing takes a while, probably 12 weeks before you really want to go hammer around the garden or the fields. But well performed, this surgery is spectacular. I've seen high-performing working dogs get back to pretty much full exertion when this surgery is well performed. There are alternatives to the surgery. So like I say, the external techniques with the de angelis and and anything you tie around the outside of the joint, as far as I'm concerned, is a complete waste of time. It's just going to undergo the same mechanical failure as the original, and whatever you put in there is never ever going to be anywhere near as strong as what nature put in there in the first place. So if you don't correct this tilt on the top of the tibia, the top of the shin bone, then you might as well not do any surgery at all. So this cut that Barclay Slocum made, the sort of semicircular cut where you then turn the top flat, is not the only technique. There have been other techniques developed. The one involves shin bone, thigh bone. The one involves actually splitting the shin bone down sort of along the length of it there, and then you break that bit forwards and you put a big wedge in there and screw it all together. And what that does is it just changes the forces, because again, you've got the big quadricep muscle over here with the kneecap there. That pulls this sort of bone, I don't know if I can show it, sort of like that. That pulls the kneecap tendon that goes to there. It pulls it forwards, and you can see the effect of that is to pull the thigh bone with it, so it's less likely to slide off the back. It works really well, and I've spoken to people far cleverer than me, the experts who figure out these things, and they tell me that's called a TTA. It stands for a tibial tuberosity advancement, because you're breaking the bone and splitting it open, and then you put a wedge in there to keep it open, or there's a special plate you can also use. They tell me that biomechanically, that should be better suited to dogs than the Slocum technique, which cuts and curves the bone, which in theory would be better suited to dogs if they just walked on their back legs. There are a few other variations on the surgical techniques. Those are the two, really the big ones that I would consider one or the other. And having looked at all the evidence, and again, the experts just keep changing their minds on which is the best, but I think the sway of opinion is really going towards the Slocum technique, or what we call a TPLO, which stands for just a tibial plateau, the top of the tibial plateau leveling operation. Another option in tiny little dogs is, instead of cutting this and turning it to get it level, if you cut a wedge of bone out like there to there, and then you pull those two bits together, that will pull that straight too. So that's a closing wedge osteotomy. But all of them are trying to achieve two things. You want to straighten the top of the tibia, and you want the patellar tendon, so the tendon that the doctor hits to check your reflexes, you want that to be at 90 degrees to the top of the bone. So all these various techniques are trying to achieve that. So if you're talking about repair techniques and you're considering the options, anything that doesn't involve cutting and resetting the bone, to my mind, is no good at all. And which is the best of all the techniques? As far as I'm concerned, from the hundreds or probably thousands I've seen done by various surgeons, certainly the TPLO has to be the number one choice. What are the disincentives to doing it? First of all, cost. It's very expensive. It's not something that just anybody can or indeed should do. It takes a lot of specialist skill, it takes a lot of specialist training, and it takes a lot of practice. You've really got to do a lot of these, and you've got to do them regularly. It's not rocket science. It's not insurmountably difficult, but it's like anything in life. You need to be educated on it. You need to be well trained on it, and you need to be well practiced on it. Success rates, I think, with cruciates that are well done, are really, really, really good. Things can go wrong. Of course, they can go wrong. I think we call that the complication rate. I think the complication rate, if we accept about 5%, so 5 in 100 will have some sort of issue, some sort of complication. The biggest complications are a loosening of the screws and the bone plate, loosening of the implants. You can also get infections in there. You can get inflammation of the patellar bands, and very, very rarely you can get catastrophic complications where literally bones can break and the bits of bone that the screws are going to can rip that out. But that's really unlucky, and I wouldn't really, that wouldn't disincentivize me. It's a bit like saying to someone, well done, Mr. Jones, you've just bought your new car, it's a lovely car, but you do realize statistically 1 in, I don't know what the number is, 1 in 500,000 people will die in a terrible car smash. So then you have to make the decision. Am I never going to drive a car again? Am I just going to walk everywhere I need to be? Or do I accept that, okay, there's a risk, but it's a small risk. So I'm happy to take that risk because almost certainly I will get to my destination in my car alive. And equally, almost certainly I'll have the surgery done for my dog and they will be fine. So for me, it's that sort of balance of risk to benefit. What if you don't repair the cruciate? Well, when I was trained, back when we just invented fire, we were taught that if the dog is less than 15 kilos in body weight, you don't need to do a repair at all. They'll do fine. So what do we mean by do fine? And the answer is, with these little dogs, their power to weight ratio is much better than the big galloping dogs. Meaning if you're a little dog and you're quite nimble and you're quite light on your feet, you can very much favor the sore leg. So you don't have to put all the weight through it. So you can favor it and without it being repaired, you can sort of get on with it and do okay. So that's what we were taught. The thinking is now no, because once you've snapped your cruciate ligament, if you don't fix it, and medications is no good, massage is no good, physio, chiro, whatever you like, is no good. You need to cut and reset the bone. If you don't do that, that movement that you've now got between the thigh bone and the shin bone, that movement leads to the two bones grinding, and very often those little cartilages we spoke about on the inside, the little beanbags or lumps of clay, because the two bones are doing this all the time, those will tear too. And remember, those are there because these two bones don't fit together very well. So once you tear those menisci, those cartilages on the inside, well, you've just lost that whole benefit that they gave of improving the congruity of the two bones. Now you've got bone grinding on bone, and that will damage the joint cartilage around the edges of the bone, and eventually you grind that away and you expose all the nerve endings beneath it. So if you don't repair the cruciate, you will have bone grinding on bone ultimately, and you will have intractable pain, and that will cause arthritis. So what do we mean by arthritis? Just to diverse a little bit. Arthro means joint, itis means inflamed. So just to say I've got arthritis is meaningless, because why is your joint inflamed? You may have just sprained it, you may have an infection in it, you may have a tumor in it, you may have wear and tear. You have to sort of quantify that statement a little bit. So when we say arthritis as a consequence of the instability that the cruciate ligament causes, what we mean is wear and tear, degenerative arthritis. So you're a bit tongue-tied. Think of it as a degenerative wear and tear osteoarthritis, which basically just means the joint's grinding away and it's damaging itself, just like an old knackered rusty hinge in your door, or one of the joints in all the mechanical miracles of your car. Things that sort of work together and rub against each other eventually start rubbing and grinding and catching until they wear each other out. So if you don't repair the cruciate, even if it's not completely torn, if it's just partially torn, but it's allowing this to happen, literally within 6 months of the injury happening, you will start to develop degenerative osteoarthritis. And what's important about that is if you delay doing the surgery until you've got a lot of degenerative osteoarthritis in that joint, you've missed the boat. It's too late, because the degenerative changes which have happened in a joint, you can't take it back. Even though you can address the problem that caused them and slow down the progression, what's there is there, and you can't take it back. So try to sort of get to this decision as quickly as you can. Am I going to repair my dog, yes or no? And you may not, for various reasons. The age of the dog, perhaps, the money involved, whatever that is. It's not the end of the world if you choose to not do it. I mean, the dog will still lead a long, happy life, except they will be hobbly and less physically capable, and they will have ultimately a dependence on medications to manage the arthritis in their knee. So it's not you haven't failed as a human being if you don't do this for your dog. We can manage it, but it's very much plan B. Plan A is put it right as quickly and as efficiently as you can. So once you've put it right, it doesn't mean you will never ever get arthritis in that knee. It just means the rate of progression of arthritis has been massively reduced, and that means the amount of arthritis you will get will be massively reduced, and it also means your quality of life and your mobility in the here and now is also massively improved. So it's a no-brainer. If you could just magic it in and get it done, of course you would do it every time. So the disincentives, like I said, are the cost of it. There is the cost of it, and secondly, there is the recovery time, because effectively we're going to break your leg, reset the knee, and it takes time. You must stick to the time that your surgeon tells you, because once you've had the repair done, all that's holding your leg together, to speak rather plainly, is a handful of screws and a metal plate, and that's nowhere near as strong as the bone. So if you go tearing around the garden, and this is the problem, because dogs feel well very quickly after the surgery, if they go tearing around and go, well, this feels fine, I'll run on it, I must be fine, they're more likely to have a failure of the surgery. So you have to commit to that rest and healing time for them. So the point I haven't mentioned yet that I should have mentioned is, how do we diagnose that you've torn your cruciate? And if you remember that we've said that the problem is, once that ligament is gone and it's not holding these two bones together, they can now move backwards and forwards. So we, as vets, we take the thigh bone in one hand, the shin bone in the other, and we try to slide the shin bone forward. If it moves forward, that's called an anterior drawer sign. Anterior is just to the front. Draw is just it gives a little bit. It just moves. So you literally would just take the knee and sort of move it. If I show you on my model again, you would take the thigh bone in this hand, the shin bone in this hand, and try to move it. It shouldn't move like that. If you can get that movement, you've torn your cruciate. That's the diagnosis. So it's not an X-ray diagnosis, because you don't actually see the ligament on an X-ray. Remember, X-rays really just see bone. You can make out vague shapes of the muscles, but imagine if I was to X-ray my arm, what you're going to see is you're going to see all the bones in the arm. You'll see a vague outline of the muscles, but you'll see no detail. You won't be able to say this is that muscle and this is that muscle. You won't see the tendons, you won't see the ligaments, you won't see the nerves, you won't see anything. So when you think your dog's torn the cruciate, the diagnosis is made in the hands of the vet. You get that movement going. To get a true assessment of that, the dog has to be completely relaxed, and not all dogs will relax, and it is uncomfortable when you move the bones. So sometimes you have to sedate them to relax them so we can move it. In human beings, what they do is they get you to sit on a table with your sort of legs towards them like that. The doctor puts his hand behind your calf muscle and tries to pull your shin towards him or herself. If it moves, there you go, you've got the diagnosis. We do still rely on the X-ray a little bit, because you get that movement when the cruciate's completely torn. But if it's only partially torn, you may not get that movement. And with time, you get a thickening of the joint capsule. Remember, there's a joint capsule that goes all the way around. You get a thickening of that joint capsule. And even though you've torn your cruciate or partially torn your cruciate, that capsule is so thickened, you can't really appreciate the drawer sign very well. And in those cases where it's not clear-cut, you would take an X-ray. Again, you don't see the ligament on the X-ray, but you see changes within the knee. You see inflammation in the knee and various early degenerative changes going on, which are just not pathognomonic. Pathognomonic is a wonderful word, meaning if you see that, then the conclusion is only one thing. It's not pathognomonic, but almost certainly if you see the characteristic changes, it's going to be the cruciate. And even if it's not completely torn, it's partially torn. So would a partially torn one heal if you just waited and gave it enough time? No, because again, the problem is the top of the shin bone is tipped back. So the forces of sliding back like this all the time, those forces that have produced the partial tear on the ligament are going to continue. So if they were enough to damage the ligament in the first place, they're not just going to go away. They are, even if you rest the dog for like 2 years in a gilded cage in your cellar, as soon as you take them out, or even if you don't, just with enough mechanical movement, it's going to tear. So it's a false hope, really, thinking the whole problem is just going to go away once it started tearing. Also, as you feel, again, shin bone fiber, if you look at it from the front, as you get that instability starting, the body on the inside of the knee, so if you put your knees together, the two surfaces that touch of your knees, the inside aspects of your knees, will form sort of a fibrous thickening. So when you feel the joint like that, sort of here, you can feel this sort of nice sort of curved mound. It always reminds me of burial mounds in Salisbury, a curved mound of non-painful, thick, hard tissue, and we call that medial buttress formation. So if you sit behind your dog, so you sort of sit like how should I do it? Sit like this. You got your dog's bum up against your chest, and their head is facing that way. And if you put your hands just on the inside of their knees, and you run your hands up and down the inside of the knees, if you feel as you go over the knee this sort of bump, and another way of thinking of it, it'll feel like the yolk on a fried egg, sort of a bump there. That's suggestive that this dog has been hurting their cruciate ligament for years, probably. And even if it's not obvious to you, that's the body's reaction to it, which suggests there is a problem there. And if they're not lame, you don't have to do anything about it. If there's no evidence of lameness at all, it means that the status quo is enough to maintain that dog. But if they're clinically lame and you sort of vacillating about making the diagnosis, then if you feel that medius buttress, that together with the x-ray changes, even in a partially torn ligament where you don't have the full, the pathognomonic, not pathognomonic, but almost pathognomonic, no, it is pathognomonic, feel, so the x-ray is not pathognomonic, but the movement, the anterior draw sign, that's all it can be, it's the cruciate. So even if you can't demonstrate that, but you see the x-ray changes and you see the changes on the inner aspect of the knee, or where the knees touch, if you put your legs together, it's a cruciate, and it needs repairing. So that's the argument for. If for whatever reason you choose to not do it, the reason when I was trained that they said if you're less than 15 kilos, you'll probably get away with not having it repaired is, yes, you'll develop degenerative osteoarthritis in that knee, but because you're light and you're nimble, you'll live with it. In the bigger dog, certainly the really big dogs, they just don't have that agility. They're not as nimble, so they cannot favor the leg, and they will put the grinding forces down, and you will get the bones grinding, and you are going to get premature arthritis in them, quite significant. It does vary between individuals, but it's inevitable. And you could manage those guys, particularly if you've got a dog who's maybe 12 or 13 years old, a Labrador, and you think you've only got maybe 2 years left. Do you want to put them through surgery? I think it's always a good thing, and we're very good at managing the pain, so don't let that put you off. And age is also no reason to not have an anesthetic. But if you weigh it up and you think, I'm just not going to do it, then that dog's also at a different stage of their lives. And so they are pretty sedentary anyway. And we put them on some sort of arthritis management medication, and we can keep them pretty mobile and pretty happy for sort of the golden years of their lives. But if you have a really bouncy sort of 2-year-old border collie, the surgery is best. If you don't do it, then yes, you just have to accept that dog's physical ability, their physical prowess is never going to be what it would have been had they not had the injury or had they had it repaired. So again, you can live with it. You're not going to burst into flames and die if you don't have it done, and you've not failed as a human being if you've not had it done for whatever reason. But just reset your expectations. That dog is never going to be as physically capable as they were before. So how does this all relate to cats? Cats can suffer cruciate injuries, just like dogs do. It's far less common, yes, and they can have the TPLO surgery done. It's extremely tricky. I've spoken to people who've just started doing it. Surgery is still always the best option for them. Cats being so light and so agile, you may, excuse me, you may well get away with the banding technique we spoke about, where you put a nylon or a wire implant that holds the two bones together together to stop that happening. And that may well be enough for cats, but that's because cats are, you know, not little dogs at all. They're completely different. Everything about them is different, but they will, I think, if you don't do some sort of bone cutting procedure, they are also going to end up with premature arthritis, and we have to manage that. So I think if anyone's interested, just Google TPLO. I'm sure there's some very elegant animated videos out there to show you exactly what happens and how the various repair techniques are done. It's one of those injuries that, you know, although, like, gosh, you wouldn't wish it on anyone. But if it does happen, every time my dog goes very lame in the back leg, I always think, well, if you have to really got something bad and serious, please let it be the cruciate, because that's the thing we are the best at repairing and the best at putting right. There are other things which are much more catastrophic. So it's an awful thing to have, but it's very, very repairable. So I hope that made some sort of sense. Remember, please send any questions or any issues or subjects you'd like discussed to nicothevet@gmail.com. I can't give a direct one-to-one consultation on anything. That's just against the law, because that's the way it is. But I do like to sort of try and open a forum and chat about things and impart sort of the knowledge as we have it at the moment. Information is constantly changing, and opinions are constantly changing, and there's sort of what's currently best practice now may change in the future when someone cleverer than Dr. Barclay Slocum thinks of something else. But for now, that's the way we would think about it. And I'll keep you guys posted if anything changes. So have a good one, and I'll see you with the next episode. Thank you. Bye-bye.